So this is a 39-year-old male with HIV and AIDS who's presenting with left flank pain. Any thoughts? Odessa or Trinity residents?
There's a delayed nephrogram in the left kidney, kind of like striations in the posterior cortex, like the enhancement is strange, and the pelvis is a little dilated.
Correct. So what's the next thing you want to look for?
Something obstructing the ureter.
Perfect. So we're going to follow the ureter. So I'm going to zoom back in a little bit so we can see the ureter better. And you can also notice there's a little bit of urothelial enhancement. Follow the ureter. And it just gradually decompresses with nothing at all, no filling defects, no abrupt transition. So you have correctly mentioned that there is delayed nephrogram. So they went ahead and did a nuke med scan. And there's good excretion from the left, but there is no excretion at all from the right. So could this be something other than obstruction?
Do they have any history of malignancy?
No history of malignancy.
And what is that like? It almost looks like, is there a dilated calyx or an abscess in the upper pole?
These were just cysts, yeah.
Huh.
Dilated calyces, correct, and some cysts, but there was no abscess.
Malak, can there be any non-obstructing stones because they could be on treatment?
So this is a very good thought.
Opaque. I mean,
exactly. This is one of the important
thoughts.
opaque stones from the antivirals. This patient actually has not started treatment. This is a very odd case. This turned out all to be renal candida infection. Just severe pyelonephritis, and the delayed nephrogram is because of the pyelonephritis, the severe inflammation in the kidney. So this was only renal candida.
And then is it like pyelitis also? Because
correct.
Infection of
correct.
Cool.
Correct. See here the wall of the renal pelvis and the ureter. It is enhancing. Yeah, so this was all candida infection. So remember, these are immunocompromised and they can get opportunistic infections actually.
And did you guys figure that out on the urinalysis, or did you actually do a biopsy?
They did the ureteroscopy.
Oh,
and
okay.
I was trying to pull up the image from the patient chart. We have a ureteroscopy image, which was also interesting, but I can't find it. Sorry.
That would be really cool to see, like white plaques or something, like shaggy appearance.
Yeah. Ureteroscopy.
Okay, I'm going to pause it.
So this is an 80-year-old male actually with a history of prostatectomy and concern for recurrent prostate cancer. And there is a very subtle finding here. It's in the right kidney, or related to the right kidney actually. Here I'm going to be helpful because it's really hard. Any
renal vein looks like a bit expanded.
Exactly. Good observation. So this is actually a branch of the renal vein, and it is, as you mentioned, it is expanded, and there is a filling defect in it. And on the coronal, it stands out a lot better. This is this branch. So this was not called actually. It is a very subtle. It's a very subtle finding, and on the axial, it's much harder to see. But you see here, there's a filling defect in the renal vein, and there is actually some irregularity along the contour of the cortex here. So the patient presented 1 year later, and this is the CT at this time. And you see here the branch that we saw last time. It's now here, and you see here this is a big mass with lobulated margins. And you see here all this area of heterogeneous enhancement, cortical and medullary disruption. So this was a papillary RCC that had barely started on the CT that was before that. So just watch out for these very subtle irregularities in the kidneys. And I want to highlight that the coronal images for the kidneys are really key. So always for small masses, for areas of lobular distortion or contour distortion, always look at the coronal images. They are very important. So this was papillary RCC with tumor-in-vein. Yeah.
Wow. That's really interesting. This looks like one of these aggressive papillaries, not like the classic little round one that mimics like a, a cyst. This looks
correct.
Like
correct.
2, like
it is enhancing more
papillary.
than the average papillary, and it has grown fairly rapidly. Yeah.
At least it still looks contained. It's still, is it going into the IVC or it's still just in the renal vein?
It's just in the renal vein. Yeah, there is some mixing artifact, but there was an MR done afterwards, and it was not in the IVC.
Do you think if you had seen the first one and you'd seen the thrombus, would you have brought up tumor in that first one?
I mean, yeah, because we don't have a cause to have mixing here, right? It's clearly a vein. I mean, we only have mixing when it's from lower extremities, but we should not have mixing in this area here.
Right. I mean, just tumor versus bland thrombus, like
I know
hypercoagulable.
I mean,
they do think like
adult.
that
Yeah.
cortex does look like there's a mass there.
Yeah, bland thrombus in adults is very rare and only a branch. And there's no compression or anything to cause stasis in just one branch. Like if there was a nutcracker or something that predisposes to stasis, I might have considered a bland thrombus more.
Yeah, I have had a couple of cases where patients are very coagulable and they've even had bilateral renal vein thrombus, but yeah, this is unusual. It's a great case.
Yeah, thank you.
So this was an older patient who came in with abdominal pain. And the finding is right here. So what would you guys have said about this? They were pretty old. They were like 82. It doesn't really look like it's attached to the gonadal vein, which went more medially. Soft tissue nodularity anterior to the iliacus here, iliopsoas.
Sorry, was it a male or a female?
Female.
And no relevant history.
Nope.
Okay.
Aarti, can we look at the ovaries lower down?
So they've had a hysterectomy. We couldn't really see the ovaries, but they were like they're 80. So like probably this triangle thing here is one ovary. It's a good thought. And I will tell you, it's related to the female gyne system, but it's not an ovary.
Okay, we've seen some weird transposed ovaries, high, low. So that's what we were thinking.
Yeah, so I can't even say I could ever predict what this was. But I just want to let you know that this is now path proven. So my very diligent fellow, Khan, read this and then he followed it up for like a few months and they decided to biopsy it. And they biopsied it and it came back benign ciliated epithelium in endosalpingiosis. So I've only actually seen endosalpingiosis in the cookie jar, cases from the cookie jar. So I just want to show you guys again. Can you guys see this? Radiographics, cookie jar?
Yes.
Endosalpingiosis. So basically it's a rare and benign entity with ectopic cystic glands lined with fallopian tube type ciliated epithelium. So the case from the cookie jar, basically there's ectopic gland filled things that are lined by fallopian tube epithelium, and they become kind of cystic. In this case, so they're ectopic, they can be anywhere. In this case, they were kind of coating the surface of the uterus, which, is one possibility, but they basically can be anywhere. So that's what was interesting about this. We were like, well, how did this get over here? And if you think about it, if it's just ectopic fallopian tube epithelial cells, It can kind of be anywhere in the pelvis. It can be along the round ligaments. It can just basically be anywhere. So I don't think this is anything we could prospectively know. But just when we got the path back, I was like, endosalpingiosis. That's the thing I always, and I think Nellie has shown that particular case here and stuff. So I now have an unimpressive case of endosalpingiosis for my file. You guys have any comments? Okay.
I mean, that's pretty impressive. Do you think did we have a prior and we know that it was growing? I mean, she's postmenopausal, right? So we assume it should be regressing by this time.
I don't know. I mean, if it's an epithelial line thing and it's just filling with fluid, I could imagine like even, a lot of benign things kind of grow with age. Now in her 80s, I don't know, but we don't have a prior.
Interesting. Yeah, that's a good one.
But we were like, what else, like, should we just bring up some kind of, you can imagine also people in their 80s, like a lot of things start turning malignant. So like, is this the beginning of a tiny sarcoma? Like you don't want to just completely let it go because I'm not used to seeing it, but okay. Just gonna pull up.
Yeah.
Okay, so this patient has recently undergone a transjugular liver biopsy. I have mouse problems today, so if my scrolling is jerky, I'm sorry. My mouse died and then I'm on this old mouse. It's hard to scroll with. But anyway, so do you guys notice anything? Focus on the vessels. I know it's hard if you're not scrolling yourself, but. So this is the hepatic artery going in. And then what do you think this is? So I'm going to scroll up through this. And then also you can see that this right hepatic vein is filling before the middle and the left. And then what is this guy?
Is that a hepatic to hepatic fistula?
Yeah, kind of. It's actually a hepatic vein to the right portal vein.
Oh, portal vein.
And then also to the right hepatic vein. So this patient underwent a transjugular liver biopsy. And somehow, I think this region here was kind of, it was directed in this region. And it kind of disrupted the portal triad such that the hepatic artery started fistulizing both with the right portal vein as well as a right hepatic vein. So whenever you see a portal vein or hepatic vein filling early on the arterial phase, you should be worried, like, why is this only this one hepatic vein filling early? And be concerned about a fistula. I can try to show you the IR images. Let's see. Might be difficult to. Anyway, they were able to see the fistula on IR, and they then went and coiled the right hepatic artery. So,
Hey, Aarti, will you scroll on the axial CT? The density of contrast almost made us think it was arterial.
this,
Yeah.
right, it is arterial because the artery is feeding straight into the right portal vein. But like, look at the direction of this vein, right? That's not like, this is not a,
Right, it's along the expected course of the right posterior division.
right, but you see how it's also bigger?
So there are two fistulae, you mean, between the hepatic artery to right portal vein first and then portal vein to right hepatic vein next?
Yeah, and actually we don't know exactly. So we don't know exactly how the hepatic vein is fistulized, but we know that the right hepatic artery is going to the posterior division of the right portal vein. And then it looks like here, it then picks up into the hepatic vein.
Gotcha, that makes sense.
Yeah. Yeah, it was interesting. And actually also there was new hemorrhage in the gallbladder. And if we went back, actually let me go back, one CT, it was a non-contrast CT. And in retrospect, the CBD was actually kind of dense right there. The biliary tree was kind of dense. And they ended up putting a chole tube in, and there was all blood in the gallbladder. So there was also a fistula with the biliary tree where, blood was going into the bile duct and then also collecting within the gallbladder. So if we go back to my CT, you can see here, it's filling with all this hyperdense stuff that wasn't there before the biopsy. So there's also like blood in the gallbladder. So yes, the one thing, transjugular liver biopsies are also done in patients if they're hypercoagulable, but because of that, there can be more complications because they're hypercoagulable. So it can be a little tricky. Okay, I'm going to stop sharing, stop recording.
Okay. So this was something, and I'll just tell you what we called it and what it turned out to be.
I would have called that like a retrorectal hamartoma.
Right. That's kind of what we said. It's in the retrorectal cystic lesion spectrum. This one didn't have much diffusion restriction for the dermoid, epidermoid, we would call. And for the residents, no connection to the spinal canal for like chordomas or meningocele or anything. Very thin peripheral enhancement only. So this got taken out, and this turned out to be endocervicosis. So very strange, but in the same spectrum as endosalpingiosis. And I found an article. Hold on one second. I will share what I found.
Never heard of that. Are you going to say basically it's like ectopic cervical glands or something?
Right. So I'll show you the AJR paper. So they say it's ectopic endocervical epithelium. It's very classically described around the bladder and urethra. So they say when you see a big cluster of periurethral or perivesical cystic masses, there's something to think about. And so they call all these three, endometriosis, salpingiosis, endocervicosis, as mullerianosis. But this is the picture they had in that AJR article. So if you kind of transpose this and put it very posteriorly, it looks like any of the retrorectal cystic spectrum. But
that's so cool, because that looks like if we saw that in the future now, we would think about this,
Right.
But your location was kind of atypical.
Yeah, it was so classic for like a tail gut cyst or something else. But histologically, they confidently on path, they said it's cervical glands, and they called it endocervicosis.
Okay. I have a question, back to your PowerPoint. You said this is all on the mullerianosis spectrum, but endometriosis has much worse implications, it would seem, because it has bleeding functional tissue, whereas the other stuff is just like glands. So they're just like fluid. Okay. Got it.
But yeah, we had not heard of endocervicosis before.
Yeah.
So it's good.
Super cool. Okay. So this is a penile ultrasound. And I'm going to show you some cines as well. But there was a lot of swelling. The patient had said that they felt a lot of swelling at the top and base of their penis that happened after having intercourse. They didn't feel the typical like sort of snap like that we think about with a fracture. And then these are the cavernosa. The spongiosa was here. It wasn't that well seen, but let me show you a cine. So when we're looking for a fracture, here, I'll show you another cine. Okay, when we're looking for a fracture, we're basically looking. So these are the two cavernosa. It's like two eyes and a nose. So these are the two cavernosa, and this is the spongiosum. And then this is the fascia that goes around all three of them. And what we're looking for is a break in this fascia and then extrusion of the cavernosum through this to say that there has been a fracture. In this case, however, there was just a lot of swelling over the this part of the penis, and there was this structure. The patient kept saying they felt this like really rope-like structure that was tender. And if you focus on this structure here, I'll show you, these are the two arteries, and then there's a deep dorsal vein, and there's a superficial dorsal vein, both of these right here. And that's where the patient's pain was. These guys, when we elongated it, there was no color flow in this lesion in this area. There were two actual rope-like structures without color flow in them. And then here, this is actually the transverse color image where there's two arteries that are lighting up and then two veins, one of which looked like it had actual, echogenic thrombus within it. And then this one, which was not lighting up. So this was basically thrombophlebitis of the superficial and deep dorsal veins. Does anyone know another name for this entity? Odessa, you can answer if you know.
Mondor's disease of the penis.
Yes, good. So this is Mondor's disease. So Mondor's disease can apply to thrombophlebitis of multiple different areas of your body. But when it's of the penis, like when it's involving these veins, they call it Mondor's disease of the penis. It's basically a sort of spontaneous, self-limited thrombophlebitis, usually just of the superficial vein, but sometimes can affect the deep vein. And they have to decide if they're going to anticoagulate them. And then they often resolve on their own in like 5 to 8 weeks. So I thought this was interesting. I haven't done that many penile ultrasounds, but most of the ones I've done have been for fractures. But in this case, like the history, going and seeing the patient, it was really helpful because he was pointing exactly to like this rope-like structure was really painful on the top of his penis, and it turned out to be this non-enhancing vein.
Aarti, any predisposing factors, like in Mondor's of the breast, they say lactating women or some other mastitis could be the cause. Is this associated with anything?
Yeah, so this patient actually did have a malignancy, active leukemia, actually. So we thought that was probably contributing to it. But online, when I read about it, it said like it can also just affect anybody. And it often is triggered by some kind of trauma, like usually intercourse-related trauma. In this case, it did seem to be activated, like, that was the instigating factor. And then I think it was Roopa says, cool ultrasound diagnosis, much easier to see on MRI. Yeah, so that was my backup plan. We went and did this on ultrasound, and I was like, if I don't know what's going on, I'm just going to go get an MRI. But we felt pretty confident that we could see that and that we didn't see a fracture. And also the story wasn't good for a fracture. It wasn't like sudden angulation or a crack or popping sound during intercourse. So we felt like all of it kind of added up more towards a venous thrombus. Okay. So this was a non-con CT. And we saw this lesion in the pancreatic tail. So just based on this, what's your differential?
Was there any trauma history?
Nope.
How old?
55-year-old female.
Mucinous tumors can calcify, I suppose.
Yeah, they can. They usually have thin calcification in the ovarian struma-lined capsule as well as the septa. And then serous adenomas like to have the central scar can have a stellate calcification. This to me is more of kind of like a pretty extensive model dystrophic calcification, but definitely thinking about MCN, especially given middle-aged female. Anything else? Other pancreatic lesions that like to calcify?
Any of the neuroendocrines do?
Yes, excellent. So 30% of neuroendocrine tumors can calcify. Okay, I'm going to pull up their MRI. So this was the T2. Not the best. Let's see. Oh yeah, here. Okay. This is what it looked like on T2.
Aarti, can you show the spleen?
Yes, spleen is here.
Okay.
You're thinking possibly splenule?
I mean, the signal kind of looked like.
Yeah, it kind of
Evil
looked like it.
Yes.
So when I think about spleen, like if it's a splenule, I think Is it following the spleen on all sequences? One of the sequences that spleen is really bright on is diffusion. So we can go here, we can see the spleen is really bright. The lesion is pretty bright, but I would say it looks kind of lobulated, and also splenial would be weird to heavily calcify, right? It's definitely restricting. And then it had this kind of, oh, there's a lot of motion here, but let's see if there was a better sequence. It had this sort of internal enhancement. And if I could convince you, back to this T2, it has almost kind of like a smudgy or frondy kind of appearance on T2.
Are there any travel history like for echinococcal or something unusual? Some infection is the other thing we were thinking.
No travel history. Echinococcus is usually liver and lung.
Right.
I've never seen it in the pancreas, but that would be cool. Okay, so anyway, we were thinking calcification, smudgy, kind of lesion with internal enhancement. This, favored to be a neuroendocrine tumor. And then also another possibility was an IPMN, because about 20% of IPMNs can also calcify, and it looked kind of frondy and stuff like that. So this was resected and was a SPEN tumor, solid pseudopapillary neoplasm. So just a couple of points about SPEN tumors. They tend to be in younger females, but can be any range. And it tends to be 90% female, but can be male, can be anywhere in the gland. And when they're small, all of their pseudopapilla are kind of crowded together. So it has this kind of frondy appearance with enhancement. And as they grow larger, they outgrow their vascular supply and become hemorrhagic. And that's why they can look cystic and solid, because they have blood centrally. But what I learned that I didn't know, even though I lecture about this at AARP, is that about 40% of them can actually calcify. So that was a teaching point for me. So yeah, this was a SPEN. So now when I see a calcified mass, I think, more commonly is neuroendocrine, even though only 30% of them calcify, it's just a more common tumor. SPEN tumors can do this, and then also IPMNs can also calcify. Regardless, it was a surgical lesion. It had enhancement within it, but it was just kind of an interesting thing because we had completely forgotten about to put SPEN in the differential. So luckily, this was a low-grade SPEN. These are low-grade neoplasms. These patients tend to do well, but they got a distal pancreatectomy for this. There's something in the chat. Oh, Malak is back. Awesome. Okay, so this was a renal lesion. Right here. You can see it has some hyperdense parts, maybe even a little bit of stippled calcifications. And then post-contrast, it's here. Between the pre and the post-contrast, it went up by about 18 Hounsfield units. So what would you guys say about that? What's your threshold for calling enhancement?
Aarti, at least 20 Hounsfield units is what we've used.
I think at least the 20 is per literature, but here visually it seems enhancing. So if you have a software that can subtract CT images, I think that would be ideal in this case, because the pre-con had some calcifications. So to find an area that specifically was not enhancing, I mean, visually it seems to be enhancing. If this is the same,
I love it. I love it. So first of all, multiple questions for you. You have software that can subtract CT?
There are some softwares that can, yeah.
Okay, we don't have that.
Just plug in a sequence like pre and post. What do you want to subtract? You can subtract any two sequences. Yeah.
Oh, okay.
I used to have it without. I don't have now, but I know there are some softwares that allow that. Yeah.
Okay. So also, as you pointed out, there's some calcification. So this is another thing. I would caution people from like maybe that's just a calcified part, but you want to take the non-calcified part and see if that part's enhancing. So for example, if I go to this posterior part here, let's see, it's 36. And then here it goes to 60 or 58. So it seems to be going up by 22.
Yeah, so this is unequivocal enhancement then.
Yeah. So exactly. So the way that we measured it the first time around was not exactly the best. Like, avoid the calcified parts, look visually, it seems to be visually enhancing, look at, make smaller ROIs and see if some parts of it are enhancing. So it went up by 22. So, I think most people say like under 10 is pseudo enhancement, above 20 is definite enhancement, and 10 to 20 is this gray zone. And maybe you should at least get a follow-up. This person got an MRI.
I'm just curious, there were two phases on the CT, right?
Yeah,
Just
only
the three
two.
and okay.
Yeah. Okay. And this is the MRI, and you can see again, it's T1 bright. And then this is, post contrast. Okay. And then this is the subtraction, but it was there was some motion, so people weren't sure about the subtraction. But if you go back to the arterial phase, one thing you can do is you can use the Hounsfield unit. In MRI, we call it AU, or arbitrary units. I only learned that recently by reading the CCLS paper, that this is what you can call MRI units. But you can see it's actually going from 492 to 845. So if your subtractions are not great, you can use these, the Hounsfield unit tool, and just see if it's going up by more than 2 standard deviations, or if it's definitely going up, here it's going up by like 300 and more than 2 standard deviations. So it was enhancing here on MRI as well. At this point, it was called equivocal enhancement. And then he came back and
UCLS likelihood score or no?
Yeah, actually,
central actually, but I'm curious to see how it looked on the T2 if these are easy to pull up.
Oh, well, let me pull up the T2. That's a great thought, but okay, so let me show you this on the T2. Actually, this is a great.
I guess I want to see if there are flow voids, and I want to see if it's dark but not a flow void. So it's not a flow void. It seems like it's definitely solid enhancing.
It's not there's no flow void. Yeah. It's not as T2 dark. You know how it was kind of like low level enhancement, right?
Yeah,
so
yeah.
Like if it is a renal mass, is it a papillary? But the other thing is just the location. We were like, is it actually a urothelial mass? In which case you wouldn't even use the CCLS score.
Yeah, the other thing with low level enhancement, you wonder if it's like a vascular leiomyoma or leiomyosarcoma or something odd.
Yeah. Okay, well, I do have the path on this, but I am going to show you.
I mean, urothelia can be well defined, but urothelial is also more likely to be like infiltrative and ill-defined.
Yeah. So, okay, this is now.
Oh, wow.
I have to load this up. 9 months later.
Wow.
Extensive lung mets, extensive liver mets. The mass itself is larger. There is another mass in the left kidney. There's retroperitoneal adenopathy. So I was like, this is the most aggressive urothelial cancer I've seen, Turns out it was not urothelial or RCC. This was actually a neuroendocrine. This is a poorly differentiated small cell carcinoma variant of neuroendocrine tumor. So super weird, unusual case, but it was a good reminder that even if there's low level enhancement, we need to pay attention and follow these up. And you can measure enhancement on MR by using the 2 standard deviation rule. And not everything that's in the kidney is either RCC or urothelial. You can also get weird stuff like a neuroendocrine. So neuroendocrine never ceases to surprise me. And all of this had developed in 9 months. So neuroendocrine, well and moderately differentiated, are often treated with long-acting octreotide. Poorly differentiated, which is basically like small cell carcinomas treated with chemotherapy. They tend to be more chemo, affected by the chemotherapy quickly, but then they respond, recur quickly. These are the ones that will be hot on FDG PET, whereas the moderate and well differentiated will be active on dotatate PET. Any comments? Okay. What do you guys think about this para-aortic cystic structure? I'll show you on the coronal.
I mean, residents have any thoughts?
Okay.
Sorry, what'd you say?
Trying to run through a possible cystic lesion in the retroperitoneum, para-aortic. I don't think it's connected. Looks like it's connected to anything.
Anything like what? What could it possibly be connected to? And it's in this specifically the retrocrural space, right?
And in general, a cystic lesion with a thin wall, and it's not pushing structures around. It's kind of confined to the shape of the structures around it. So it's not a high pressure lesion, it's a low pressure lesion. What do you think of? Let's say this was in the neck in a PEDS patient.
Oh yeah,
It's like a hyperoma.
yeah.
Lymphangioma, technically, that's a common location for these.
Yep.
And the cisterna chyli lives close there, a little bit more inferior, and usually more to the left than to the right. But the thoracic duct will be crossing that area.
Yep. And actually, I'm not sure usually to the left versus the right. I thought it's usually to the right, but
Oh, really? Okay, maybe this is the right.
no. But so yeah, that's exactly what we were thinking. Like, is this a lymphangioma or is this what they call a megacisterna chyli? There are case reports of a megacisterna chyli that look similar to this. It's more convincing. So I think this is like the cisterna chyli kind of, it can have all these branches. So the cisterna chyli is basically the lymphatic, channel that drains all of the abdominal lymphatics, and then eventually goes and joins the thoracic duct in the chest. Our interventional colleagues might access it in order to get into the thoracic duct to do a lymphangiogram and thoracic duct embolization if they have a chylothorax. But anyway, we don't have the final answer to this, but the main thing is to not be concerned about it. If I see a blobby fluid filled structure basically anywhere in the abdomen now, I kind of always think about a lymphangioma, which are usually like sort of benign lymphatic sacs. They tend to be blobby and they can have some septations. But in this particular case, we also, given the location, we were like, oh, this could be kind of related to the cisterna chyli, and just be like a cystic ectatic dilatation of the cisterna chyli. They don't do anything about this. They're usually asymptomatic. It's not a reason to go and embolize the cisterna chyli or anything like that. But
I have noticed in some of these cases, if you look at the 5-minute delay, you might see a little bit more, a little bit of contrast in it, especially if it's over 10-minute or 20-minute delay, it might start to fill in.
Really? You
Yeah.
mean if it's a veno-lymphatic malformation or something?
Even if it was lymphatic, but if the injection was not great, if the contrast injection had something, and I don't know why it drains. Yeah.
Okay. Ours did not seem to be
dark. Yeah.
But that's a good point though. There is also, the spectrum of veno-lymphatic malformations, which can be a combination of venous and lymphatic structures. In children, those are the ones that they might embolize and stuff because they can be quite large. They can have phleboliths. But anyway, this one was on the spectrum of lymphangioma versus megacisterna chyli. And just know that this entity exists. Sometimes on CT, this can be mistaken for a necrotic lymph node. It's usually not this big. Usually they're if it's a small thing here, just remember that the cisterna chyli is over there. Okay. What do you guys think of this structure here? I also have an ultrasound. Let's see if I can try to pull it up with. Hold on, let me pause for a sec. Okay, so this is the ultrasound of the gallbladder. You can see it's got a lot of sludge in the lumen and then a super thickened wall that has fluid fluidy kind of material and debris.
So you have in the chat suggestion from UAMS radiology, which I kind of like.
Yes, yeah. So they said XGC, and I think that's what this is. I'm not going to have path-through if this patient's older, and they have a lot of other issues, and they're not like having like they're not super sick like acute cholecystitis, but that makes sense because xanthogranulomatous cholecystitis is a chronic inflammatory process. But we did get an MRI, and you can also now see it's not the evil gray of tumor. It's basically like in the wall, you can see actually the mucosa is kind of intact, but in the wall, you've got tons of fluid expanding here. So that's all of the cholesterol and xanthogranulomatous inflammatory change with lipid-laden macrophages and lots of neutrophils and inflammatory cells. So this is a chronic inflammatory process. We also did think like part of the wall was a little disrupted here, but yeah, I just thought it was a beautiful example of what is probably xanthogranulomatous cholecystitis. This is a chronic, it ends up becoming a multibacterial infection. Sometimes it mimics a tumor more. It looks less fluidy and more like evil gray of tumor, and they can't distinguish it from gallbladder cancer. And sometimes it's like a retrospective diagnosis, but just a really gorgeous case of it. So that's it.
So this is a young patient. He's only 18 years old, and he has a palpable lesion in his right testicle. So he came and we did an ultrasound, and this is actually what he's feeling. And images here. So these are not vessels. There was nothing moving in them. These are just dilated structures at the level where the epididymal head will be living. So these are just dilated tubular structures. Do you mind pausing recording a little bit? So keeping that in mind, the patient also has a CT. And what do you notice in the CT? He has had no abdominal surgeries before.
Right kidney's missing.
Exactly. And this is the left seminal vesicle. There's nothing on the right. So congenital absence of a kidney, associated missing seminal vesicle, and obstruction of the ejaculatory ducts. So this is mesonephric malformation. This is actually Zinner syndrome. Yeah.
Very cool.
So these are all dilated efferent tubules because they have no place to drain, and it's only on one side. It's unilateral, the same side as the missing kidney. It's on the right side.
Nice. So these, you're saying they get dilated because the seminal vesicle is missing, so they can't drain into anything.
Yeah.
Okay. Cool. Are they going to, do they do anything about that?
No, I don't think there is a need to do anything. Just reassurance.
Okay. Because the other testicle should be working.
Yeah. Yeah. Oh, sorry. So he's ejaculatory duct obstruction. So that's what's causing it, not the seminal vesicle. They also have seminal vesicle cyst associations, but he had the ejaculatory duct obstruction is what's causing the efferent tubules at the level of the epididymal head to be dilated. So this
Awesome.
is thinner.
Okay.